Okay, so good afternoon, everybody. Thank you for the honor of getting to speak to you and share some of what I have to say. As was mentioned, I am a physical medicine and rehabilitation resident. I'm at the University of Minnesota. And just a couple things before I start. I just want to mention I have a website, foampmr.com. I have a YouTube channel. This is kind of customary when residents or doctors talk, just any disclosures or disclaimers. I'm not giving out any medical advice today, so anything I say is for educational purposes only. If you did have any questions, make sure to speak to your healthcare provider. While I do go to the University of Minnesota for my residency program, this talk and opinions are my own, not my residency or employers. And I'm giving this talk to help teach, but I don't know, and I think a lot of people probably don't know exactly how medical schools are going to sort of be viewing hours and things like that. I think that we're all just trying to do as good as we can. So I'm not sure if we'll be able to get through all of these in the time period, but generally this is kind of what I like to talk about, at least as an initial kind of setting. Introduce myself, how to be a medical expert. The reason I talk about being a medical expert is because I think anybody that's in this chat right now, they're interested in becoming a doctor. And I think like other things in life, if you don't try to be amazing, then you're not going to be amazing. And one thing that I've learned, I'm in my third year of residency now, is that doctors in the hospital that end up developing a really great reputation and end up getting known as leaders in the field, you don't have to reinvent the wheel or do anything crazy. You just have to do what you were taught to do. If you do what you were taught to do and you don't cut corners, you'll end up being an expert. I'm going to talk about physical medicine rehabilitation, which is my residency, talk about some patient encounters that will kind of help you understand the field a little bit more and also kind of make this as much like shadowing as possible. If we do have time, I can talk about some medical school application tips, letters of recommendation, personal statement, so on and so forth. If anybody does have any specific questions that we don't get to answer, you can see down here in the bottom left hand, that's my handle for Twitter and Instagram. So feel free to reach out to me with any questions that you have there as well. So a little bit about me. I'm from the East Coast. I'm currently in Minnesota, but I grew up in New Jersey in a suburb right outside of New York. I went to medical school in New Jersey, Rowan University School of Osteopathic Medicine. If anybody has any questions about what going to osteopathic versus allopathic medical school is like, which is DO versus MD, I'd be happy to talk about that as well. I did my internship in Staten Island, which is one of the boroughs of New York City. I'm currently doing my PM&R residency at the University of Minnesota. And for my fellowship, I am applying to pain management fellowships. I could talk about that as well. I'm in the educator track at the University of Minnesota, so that's for people who teach and plan to teach medicine. So part of my education is not only PM&R residency, but is also on teaching medicine. We get training and things like that. I help to design the virtual medical school rotation. So as shadowing opportunities are limited, the same has been true for medical students. They haven't been able to necessarily rotate in the hospital. So we designed a virtual medical school rotation with simulated patients and all kinds of really cool things. And I'm very interested in free open access medical education. You can learn more about that at my site over there. One last thing is I'm also running a leadership training program for pre-med students, a lot of different other things. It's not really the purpose of this talk, but feel free to reach out to me if you're interested in any kind of leadership experience or opportunities. So why does it matter who I am and why think about that? And this is not only for me, this is not for me to, toot my own horn, but anytime you listen to anybody speak, I'm honored to be the first speaker on this platform, but you want to really understand what motivates the person. What did they do? What are they doing? What do they want to do? And one of the reasons for that is because as you are going to be advancing your career, if you just said, yeah, I listened to a talk about PM&R from Jonathan Reisman, the person that would be interviewing you would want to know, how do you reflect on that? And the last time I saw there was 40 something people in the chat, maybe it's more or less by now, but everybody can give a different explanation of what they got out of it, how they reflected on it, what it matters to you. And that's kind of what I talk about also on some of my other platforms is because everybody learns the same stuff. We all take the same MCAT, we take the same board exams, but what you do with it and how you internalize it is what's going to make you different as a doctor. I talk about a lot of these different things, and as I mentioned on YouTube, I have a number of these different topics. So anyway, I like to recommend, as I mentioned, I like to recommend to be a medical expert, but try to hit home runs. And ultimately, lousy situations happen, such as COVID-19. I think we all agree that's a pretty lousy situation. What do you do in those situations? So one way you can talk about something like this is, yeah, you know what? I wasn't able to do my shadowing. I wasn't able to go do X, Y, or Z that summer. I was planning on doing a mission to Nicaragua or, you know, whatever you might have been planning on doing this summer, but you can explain how you do something instead, and that's going to happen in the hospital. People make mistakes. There's something called M&Ms that happen in the hospital, which stands for morbidity and mortality. It's a really tough topic when people make mistakes, or even if a mistake didn't happen, but if something bad, if there was a bad outcome for a patient, and we talk about it, and the goal is what to do better in the future. So unfortunately, the best doctors in the world, they're going to have bad outcomes every now and then. But part of being an expert is figuring out how to use every opportunity in front of you to improve yourself. There's all different ways that people learn. We can talk about that another time. So physical medicine rehabilitation, which is my residency. So it is a medical specialty. The other name for it is PM&R or physiatry. And the way that is best to explain this, I think, is that we take care of seriously injured patients. Now, there's all different types of serious injuries you can have. You can be hit on a football field. You can be in a car accident, a skiing accident. You can have an amputation. But you can also be born with some congenital disorders or impairments. You can be born with out a limb. You can be born and in the first 2 years of life, you can get cerebral palsy. So these injuries, somebody might get patched up in the operating room or by a trauma surgeon, but then what does the rest of their life look like? And a lot of these different injuries, because medicine is really great and evolving and we're able to keep people alive, now we're seeing a lot of new medical conditions. For instance, COVID-19. There's a branch of PM&R right now dealing with COVID-19. So if you've heard that patients are maybe on having issues months later, not able to walk, not able to breathe well. There's so many things that are rapidly evolving and coming out. Myocarditis, which is affects the heart. So we take care of those medical conditions, but that's on the inpatient side. We also take care of things on the outpatient side, musculoskeletal things, sports injuries, pain management, non-operative solutions. So a lot of times people think, oh, I hurt my back, I hurt my knee, I have a neck problem, bulging discs, whatever it is, and they think they need to get surgery. We try to provide non-surgical options or minimally invasive surgical options that we can perform to help reduce pain and improve function. And that's the next point there, function and quality of life. So just like lots of areas of medicine are focusing on diversity and inclusion and humanism and really important things that we're now bringing to the table. Our goal in our field is to make sure that people have good function and quality of life. It's not enough that you get home back to your house. We want to make sure that your life at home looks good. Do you need a specialized customization for a wheelchair? Do you need some other type of thing that we can do? We really try to think outside the box, constantly revolutionizing things to make sure you have good quality of life as possible. As I mentioned, there's inpatient and there's outpatient focus, and we do procedures to maximize quality of life. Talk about that in some other things. I'd be happy to answer any questions about that as well. Subspecialties of PM&R. So for anybody that's not aware, when you finish medical school, your first year out of medical school is called your internship. Now, some residencies, you jump into your 4-year or 3-year or 5-year residency program, but some residencies, which they have what are called advanced programs, and that means you do an internship and then you do a separate residency afterwards. So that's what I did. I did an internship in internal medicine and then residency in PM&R. And then, so PM&R would be my specialty. And then for subspecialty would be the fellowship that you do afterwards if you do a fellowship. So we have sports medicine, traumatic brain injury, which includes concussions. So veterans returning from service in the Army, or NFL players who get concussions, or even just your a 14-year-old that gets hurt in school. We deal with concussions, spinal cord injury, pediatric rehab, cancer rehab, pain management, among other things. So a few examples of the spectrum of PM&R, and I'm going to talk about the same patient, but from a few different scenarios, and you can see how the care kind of evolves. So a 25-year-old male presents to the emergency department. This is a made-up patient. Brought in by ambulance after motor vehicle accident. We have a lot of acronyms in medicine. I'm just trying to expose you to a lot of what you'll see. Pedestrian versus truck at highway speeds. Glasgow Coma scale of 7. So the GCS is a scale that goes, I think the minimum score you can get is a 3. It goes all the way up to 15. Generally, if they're 8 or less, they need to be intubated. CAT scan of the head showed an intracranial hemorrhage, and the patient was taken for urgent neurosurgical intervention, right? So this was in the emergency department. Let's flash forward. Patient is now being admitted to rehab. So made it out of the emergency room, went to the ICU, went to general medical floor, and now is going to rehab. So hit by a truck at highway speeds, and you'll see how we're kind of changing the way we're talking about it. We're not going to include all of the same information. We're going to include some of it, but we're going to give a different spin on it. He was intubated on the scene. GCS was 7, neurosurgical evacuation and shunt placement, 2 weeks on ventilator in the ICU, developed pneumonia. He's on vancomycin, that's an antibiotic, since July 7th, cannot eat, has a feeding tube, right? So that's flash forward. Now let's flash forward again. 25-year-old male presents to your clinic. So now this is an outpatient. He has a traumatic brain injury 7 months ago. He is feeling better, but has trouble seeing out of his left eye. He was previously an A student in math, but he's having a hard time in this subject. He is still having a hard time moving his left hand. So, we can't really delve into each one of those medical problems, but this is affecting this patient's vision. This is affecting cognitive skills and math, even though the patient was an A student before, having a very hard time now, and patient is having a hard time moving his left hand. I talk a little bit more about brain injury, recovery, and neuroplasticity. Right here, I could just take a question break before I move on at all. I like to see if there's any questions here before moving on to anything else. Feel free to ask in the chat. Otherwise, I can continue with our next case. If you have any questions specifically about brain injury or any of those topics that I've talked about up until this point, I can give you a minute or so before moving on. So I see one right here. Let me just stop the share for a minute. So what do we have here? Why did you choose DO over MD? So I mentioned I'm from New Jersey, and I was getting married. I was in my year prior to applying to medical school. I was engaged. We were planning to get married. My wife was going to have her last year of undergrad in Manhattan, and I only wanted to go to medical school in the New York or New Jersey area. Everybody has different reasons for applying to different places. So I applied basically to all of the schools in New York and New Jersey. The preference was to stay in New Jersey. And so I applied to both MD and DO. And then as I learned more about the different schools, I ended up learning about what DO schools are, and with what my goals were, DO schools seem to really match up well with them. They kind of focus on the entire situation for a person, not specifically just the problem at hand, but it's a very holistic view. You learn some other areas of how you can help patients out. Is it harder to get into medical school in New York? I'm assuming that question is in New York as opposed to New Jersey, or maybe the question is New York, compared to the whole country. I don't really know that it's harder to get in New York. The one thing I will say about that, and this would probably be true about New Jersey as well, is areas of the country with a really high population density. So there's obviously a very high population density in areas around New York City and including New York City. So for instance, forget about even medical school, but just my residency for physical medicine and rehabilitation, there were 20 or so students from my medical school that applied to PM&R residency, which is a really high number as compared to my friend who's my co-resident. He had two people apply to PM&R residency from his medical school. When you have only 2 people applying from a medical school and that medical school has that residency, there's a very good chance that they're going to get into that residency. Whereas in my school in New Jersey, there were 20 of us. It's much harder for 20 people to get in to regional schools. So that's the best I can do to answer that question in this case. What is some advice you would give from a DO student who wants to pursue a competitive specialty? As a DO student, it can be harder compared to MD students. So like everything in life, you have to show your value and your advantage, turn everything into an advantage. So for instance, you know, obviously this is a question, you know, on a Zoom chat, but assuming you were on an interview, you would obviously be explaining why you are better as a DO student for the job. Do you get what I'm saying? Now, that's not just making it up. There are skills that you have that other people don't have. There are programs that specifically are looking for a certain amount of DO students. You can make the case that you have, for certain specialties, you actually have an advantage applying as a DO student over an MD student. The two specialties where you do not, to my knowledge, are plastic surgery and neurosurgery, which are still very big on MD over DO. But a lot of the other fields, you will actually have an advantage as a DO, but again, it requires some strategy. You can reach out to me separately. How is traumatic brain injury classified? So there are a few different ways of going through it, but there's mild, moderate, and severe traumatic brain injury. So concussion actually counts as a traumatic brain injury, but there's a lot more talk that can go into it from that. And then I'll give one more question and then jump back into the next case, but we'll continue for the questions afterwards. In this case, does the same PM&R doctor look at the same problems, or does the patient have to see different PM&R specialists? So, so that can be a little different depending on what setting you're in and how you like to practice. But for instance, let's say I was the doctor there, so the patient comes in, and I'm the PM&R doctor, so I would be taking care of their brain injury, their medical issues if they have hypertension, some of their functional issues, their feeding issues. But let's just say the patient had surgery, right? And we said that this patient had had neurosurgery prior to coming. So as a PM&R doctor, while I learned neurology, I'm not a neurosurgeon. So anytime somebody has neurosurgery, like anything in medicine, there's going to be follow-up afterwards. So as a PM&R doctor, you work kind of like as a quarterback for a team with lots of different specialists. So you would ask certain specific questions to the different specialists, like you would ask the neurosurgery team, what do you want from us to do next? If they don't have any specific goals, then you can do it however you want to do it. And it's really to your level. And then kind of we went to the outpatient setting. So yeah, that same patient could see you in your clinic afterwards. Again, some people only want to work inpatient, some people only want to work outpatient. That's true in any field, really, I think. But the same doctor could take care of this patient and have continuity of care and might take care of this patient for the rest of this patient's life. Into the next case here, and then take a look at some more questions afterwards. So our next question is, an 18-year-old male presents to the emergency department, brought in by ambulance after taking a hard hit at a football practice, could not get up off the floor, moving arms and hands but not moving feet, cannot feel right leg but can feel left leg. I know there's another male here, could just as easily be a female. I didn't mean to give two males, there was no gender specific things there. And so this patient now, right, moving arms and hands but not moving feet, cannot feel right leg but can feel left leg. So that was initially, right, presented to the emergency room. Moving arms and hands but not feet. Cannot feel on the right but can feel on the left for the legs. Now presents to rehab. 18-year-old with spinal cord injury after being tackled in football. Underwent surgical fixation of cervical spine at the levels C5, C6. He has a Foley catheter to urinate. He has not moved his bowels since the injury 5 days ago. He is unable to move his right leg. He can dorsiflex his left foot. Dorsiflexion is the opposite of plantar flexion. Plantar flexion is what you do with your foot when you step on a gas pedal, pushing down. Dorsiflexion is the opposite, lifting it up. So now what? Now we're jumping ahead. This was an 18-year-old. Now, 2 years later, was injured in a football accident 2 years ago. Spinal cord injury was rated C5 Asia A. So that is a grading, just like we said, traumatic brain injury can be graded mild, moderate, severe. Spinal cord injury has its own grading system, walks with an exoskeleton. So in PM&R, we deal with a lot of these different modalities to help people walk better. He's on a daily bowel program. So depending on where your level of your spinal cord injury is, you might not be able to move your bowels anymore or to urinate. And there are different types of medical that we allow to move their bowels. He asks about spinal cord stimulation. So without getting too much into spinal cord stimulation is when I saw 2 cases of this on Friday in the operating room. It was very, very fascinating. Essentially, through the back, electric rods or rods with electric components are inserted into the spinal cord, and there's you can control them via an iPad, and essentially you are stimulating the spinal cord to send in information that's coming from the iPad, essentially going through electrically. It can reduce pain, it can help improve motor activity, a lot of other really cool things. We are at 2:23 now, so I can talk a little bit about some of this, just to show you about some of, how I like to approach things. Medical school and residency strategies. So some things to think about is, what is your story? Everyone has a different story. And even though our stories are all going to be somewhat similar in lots of ways, we might have similar themes. You maybe had somebody in your life that was ill. You maybe grew up and you knew somebody who had a condition. Maybe you had a certain experience and something is motivating you to become a doctor. Plot out the details of your life and sit down. You could do this for an hour, 2 hours. I have a talk up on my YouTube about just writing a personal statement in general. And so you plot out these details, and I'm talking everything, like went to summer camp here. This was my friend. He was my friend. She was my friend. I played guitar. I took lessons from, it could take you hours and hours. Literally get out every detail. See how you can weave them together into the most compelling story that is true to who you are. Consider what your strengths are, what are your weaknesses. You have to own up to both of those. Talk about your strengths, why they're going to make you awesome, and talk about your weaknesses. And when you talk about your weaknesses, you have to talk about how you're overcoming them. And if you're not overcoming them, now's a good time to start to think about how you might overcome them, and think about what you can offer. There's nobody that doesn't have weaknesses. And a lot of people that apply to medical school typically have done well in a lot of situations in their life. You may have a type A personality. It's okay that you have things that are weaknesses. We all have them. What's not okay is if you're not aware of what they are. So it's good to try to take some time to think about what they are and think about how you can best augment them. And what can you offer? We have to learn in this process how to humbly brag, essentially. And not brag, but somebody wants to know, when you're sitting in front of them for an interview, they want to know why should they take you over the thousands of other people that have applied. So you want to show what's awesome about you, and everybody has things that are awesome about them. What's challenging is reflecting on them in a way that you sound like a jerk, basically. Let's take a look at some of the other questions here. So, can you give an example of cancer rehab or pediatric rehab? Absolutely. So I had a patient that needed cancer rehab. This patient had a stroke, and then, so stroke, for anyone that's not completely aware, it's like a heart attack of the brain, essentially. You get oxygen disruption to the brain. It can happen either because you have a bleed in the brain and then blood doesn't go where it needs to go, or you can have a clot and then the blood doesn't go where it needs to go. And so essentially the patient seemed like they were having a stroke, but after imaging, they realized the patient didn't have a stroke. The patient actually had a brain tumor. And so the patient needed chemo and radiation, and chemo makes you very, very weak, and radiation can make you very weak. And so this patient got chemotherapy, and basically, because they did not participate in their next batch of chemotherapy, and they needed to go through rehab, but they were not strong enough. So we actually had to get this patient stronger so that they could continue to get more therapy for their cancer. That was just one example. There's lots of other examples, but that was one. It was really interesting. And then pediatric rehab, absolutely. So one, just like the other cases I spoke about, unfortunately, traumatic injuries occur to children as well. So it's kind of a similar analogy. But then specifically, one case that I had for pediatric rehab is there are there are children that are born, as I mentioned, with different congenital, hardships, or however you want to talk about it. And it is important to talk about it in a way that is sensitive. Example of appropriate terminology would be we try, after an amputation, we try not to call what is left after the amputation, we don't call it a stump, we call it residual limb. So we try to be very mindful about speaking about these things sensitively. So for example, a child that has cerebral palsy, so they are not able, let's say, to move their leg as well as they would like to move their leg, they can have a procedure called a rhizotomy, where certain nerves are actually cut in their spinal cord to help improve the way they move their leg. But then they need to come to rehab afterwards and need to learn how to, not only how to rewalk, so we're not physical therapists, but we manage the medical healing side that allows for nerves and their medical situation to improve in a way that would be ideal for them. So that's one example for pediatric rehab. Favorite aspect about PM&R. So my favorite aspect is them kind of are the same. So PM&R is a really, really fun atmosphere. And one of the reasons it's fun is because from the get-go, we are all about team play, team management, working as a team with different specialists, different types of rehab doctors, different speech therapy, occupational therapy, physical therapy, and we try to view our patients in positive lights, like I mentioned. So it's just an uplifting day. You know, there are things that people go through that are challenging, but you feel good about your day. And I would be lying if I didn't say that we have an awesome quality of life compared to a lot of the other specialties. As a resident, my official hours are 8 a.m. to 4:30 p.m. That's as a resident. And, you know, you can imagine medical residents, they're often sleeping in the hospital, crazy, not seeing their family. Our quality of life really is kind of great. We get lunch breaks during the day. You know, it's really good. So not that we don't work hard, but there's a lot of balance. So we can enjoy our lives also, which means we can come back and give our patients a better quality of care because we're refreshed. So PM&R is definitely awesome for that. There's a lot of amazing other things about it that are awesome, to be honest. Could having any ventricle ruptures cause problems with shunt placement? If so, what would you have to do? That's a really great question. That's a little bit better to be answered by a cardiologist, given that that's more of an interventional cardiology kind of question. So I can give my answer to it, but again, this is not medical advice. This would just be educational. Why we learn, and I'm going to be giving a talk in a couple of weeks on why we have to learn the pre-med content. As a pre-med student, I thought that I was learning organic chemistry, physics, calculus. I thought I was learning all of these things just because they have to filter who gets into medical school or not, or make it really hard. I learned how to sort of think through these areas in ways that help me as a doctor. So for instance, you know, I graduated from medical school in 2018. There are doctors practicing now that graduated from medical school 20 years ago, 30 years ago. In 10, 15 years ago, in 10, 15 years, a lot of what's going on is going to be totally new from the time that I graduated 2 years ago. You have to be capable as a doctor to constantly learn and adapt and apply and think critically and figure things out. So the way I would figure this out, so think about it, right? Then to have a rupture in the ventricle, you're going to have an immediate impairment in the structural integrity of the heart. So imagine if you have, you know, the anterior wall of your ventricle ruptures near where your aortic valve is. So, well, let's say you wanted to put in, you know, a prosthetic valve. If the integrity of the ventricle is damaged, you're going to need to approach it differently. Now, I'm not an interventional cardiologist, so I don't know how they would do that, but, you know, similar to like if you get a hole in the side of your car, you know, that hole needs to be patched up. But if the hole is closer to the window, you might have different tools that you need to use because you don't want to shatter the window. So same would be true for the heart. As a DO in PM&R, how often do you use osteopathic manipulative treatment? So I actually use super frequently, but I use the philosophies very frequently. So for instance, in pain management, I'm currently on my pain rotation. I mentioned I want to do a pain fellowship. You cannot just treat the spine. So if somebody has back pain, they might have been in a car accident. Maybe they had a slip disc in their back, and now they're presenting to your pain clinic with 10-year history of pain. Their pain is not even necessarily coming from their initial injury now. The injury to the vertebrae caused them to, you know, slump forward or to the side so that they won't hurt it, which ended up ruining their posture, ended up giving them spastic, you know, paraspinal muscles. And somebody who maybe didn't go to an osteopathic school would you know, not necessarily have learned about some of the things that we would have learned about in terms of how one thing kind of leads to the next. I think it's a concept that is intuitive to anybody ultimately, but we tend to focus a lot on those things and on autonomic facilitation. If there are any DO students in the room that would know what that means, otherwise that would be for another time. Advantages of pursuing osteopathic school. So I touched on that a little briefly before. You learn an entirely different approach to problem solving. I think that nowadays in 2020, the public, and ultimately the public, are your consumers. Business, but you forget about money even. You want to be good at what you do, and you want to have patients that want to choose you as your doctor. And so when you have a broader skill set and more tools in your toolbox, so to speak, you're going to be able to offer a lot of things to your patient. So that's definitely one advantage. Another advantage is that people are interested in, so the 3 tenets of osteopathic medical school are that we treat the mind, the body, and the spirit. And I think historically people would have laughed at you if you talked about the spirit or the mind. They would have, you know, a doctor from 40 years ago would have said, get out of here, you know, what are you, crazy? Like go meditate in the hills or whatever. But that's, public respects meditation. LeBron James meditates before basketball games. You know, like it's a very prevalent practice, and we're aware that those things are good for us. So we definitely incorporate a lot of those philosophies. Difference between working in PM&R and physiotherapy or occupational therapy. So as I mentioned, PM&R, we're treating the medical side of the injury. So we're not doing the therapy, but we would say based on this type of injury and what this person has experienced, they would benefit from, you know, physical therapy or occupational therapy, just like we might say they would benefit from surgery or they would benefit from something else. So we work as a team with those therapists, but we're not the ones actually doing the therapy. Just like we're a nutritionist to come see the patient. It's because I've identified that they have certain nutritional needs, but I'm not the one that's going to necessarily calculate what amount of protein they need. So that's one, but then there's other things, you know, we don't only, like I mentioned, do therapy, but, you know, pain management, things like that in an outpatient setting, sports medicine, sideline coverage. So we do, you know, sports coverage on the field as well. We got 3 more questions. I think we're getting down to the wire here, so I'll try to just hit them. And if there are any other questions, feel free to reach out to me directly. I'll give you there in the chat. Oh, sorry, I sent that privately. Let me give that to everyone. Reach out to me on Instagram or Twitter, Dr. Jon Reisman, and on YouTube if you'd be interested. You could subscribe. It's Dr. Jon Reisman. Link is in my bio on Instagram. Oh, somebody sent me, it looked like a private question, so I will not read that one out loud. And I would suggest to that person, message me, you know, in another forum. So how would you treat a patient who is presenting with symptoms of vertigo? So if somebody has vertigo, you know, you have to understand what type of vertigo it is. So there are different physical, and so I can answer that question more generally, not necessarily even about vertigo, but how do we do anything? Somebody comes into your office as a PM&R doctor, in really any area of medicine. So first thing you do is you take a history, right? And so if anybody's worked in a medical setting or done any scribing or anything, so the way we write our notes, it's called SOAP notes, SOAP, and that stands for subjective, objective, assessment, and plan. And not even just when we're writing the notes, but when that you stay strict with that process, SOAP. So subjective is, what is the patient telling you? And it might be false, right? Like the patient might have a torn ACL and they're like, yeah, doc, like I tore my meniscus. And they actually did not tear their meniscus, they tore their ACL, but they're telling you that they tore their ACL. Now, you know after you did your physical exam that they did not tear their ACL, that maybe they just bruised their kneecap or tore their meniscus. But when you're presenting to your attending physician, when you're starting off, you would say, patient comes in, 3-week history of knee pain. The patient reports that they tore their ACL, even though you know already that they didn't. But you're in the subjective, so you're saying exactly what happened. You're like a reporter. You're just presenting the facts. Then you go to objective. Objective is where you give the facts that you have found. So, you would say, while the patient reported exam, the ACL was intact as evidenced by a negative anterior or drawer test, a negative Lachman's test. However, Thompson test was positive, patellar grind test was positive. Again, I would not say yet that I think the patient tore their meniscus. That's where I would go in assessment. So now that I'm in assessment, upon review, this is a 24-year-old female with past medical history of XYZ, presented with 3 weeks of whatever. Based on my exam and whatever, I believe that she tore her meniscus. And then plan would be, I think we should get imaging, and not just imaging, that's a little broad. I think we should get an X-ray followed by MRI. You say why X-ray, why MRI? And so how does that relate to the question about vertigo? So you have the history. What did the patient tell you? How did the injury happen? Then you have your physical exam, but then you get imaging, and it tells an entire, so if there might be imaging needed for the vertigo. But again, for the vertigo, different types of physical exams that you would do. There's different reasons that somebody might have vertigo. There's different reasons, it can be, there's something called benign paroxysmal positional vertigo. There's labyrinthitis. There's lots of different reasons why somebody might have a certain symptom. That would be true for vertigo. That would be true for the knee. So general, you want to figure out what is the cause. In the event that the person asking this question believes that they or someone they know has vertigo, as I mentioned in the beginning, this is just educational, not medical advice. So I would encourage you to reach out to a medical provider if that's something that you have a question about. Would I ever work with physical therapists or refer patients to them? I would do that every day. So if somebody comes in and they have pain, first of all, a couple of principles. One, opioids are not good for you. We know that now. We didn't know that long ago. I tore my ACL twice. I was given like a treasure chest of Percocet. Nowadays, I would never in a million years give a patient the amount of Percocet I received when I tore my ACL. But I tore my ACL, 14 years ago, and we didn't know what we know now about opioid medication. So for instance, a couple things. One, we try to avoid opioid medication. It might have some short-term utility, but it can be very harmful to the patient long-term. Not just because of overdose and things, but it actually makes their pain worse. And then two, physical therapy. You need to get stronger. And one thing about that, I get questions about chiropractic a lot. So in general, and what I would say the same thing with physical therapy, same thing with acupuncture, when someone has an injury, there is a role for being, the same thing would be about massage, osteopathic manipulative therapy. There's a role for having somebody else do something for you, or now physical therapy, you participate actively, but let's say chiropractor, passive modalities, they're passive in that somebody else is applying the treatment to you. We don't believe, at least in our area of medicine, that that is a long-term solution. if you're going to need to go to get acupuncture every single week for the rest of your life as a result of your injury, we would think that you might have a problem that is not being addressed. The acupuncture is maybe like taking Tylenol. It's making the pain go away, but it's not saying acupuncture isn't a good thing to get. It's not a knock on acupuncture, but same thing I would say with physical therapy. But physical therapy, absolutely, we recommend it every day because a lot of people, myself included, tore my ACL twice, had physical therapy a bunch of times, and then a few years later, my knee was hurting again. And I thought, oh crap, did I tear my ACL again? I started, exercising, riding the bike, doing all these things. My knee was just getting worse. I needed physical therapy. They were like, hey, you're doing all these like big time exercises. You don't need to be doing those. What you need to do is these little like, like it was basically Pilates, basically I needed to be doing these little muscle stabilizers. You go to a gym, you go to a personal trainer, they're going to have you, do what Men's Health would have you do or Women's Health would have you do. But a lot of times you need physical therapy, you need a trained person that the tiny little stabilizing muscles that need to be treated that we would overlook often if we went to a gym. And I think that that's it for the questions. As I mentioned, these are my contact here. Feel free to reach out to me, on any of my other platforms. And I do talk about not only PM&R, pain medicine, and other topics of PM&R, but getting into medical school, the process, and getting into residency. Personal statement, letters of recommendation, leadership opportunities. I mentioned I had that leadership program, but I want to thank our hosts for having me because this is a really great platform. They're really providing a lot of great stuff for you. Hopefully I lived up to what they were looking for here, but I'd be happy to come and help out in any way I can, but definitely stick with them because I think they have a good thing going here. And good luck to everybody in your individual paths. As I mentioned, any questions, feel free to reach out to me.